The topic will be the understanding protective effects in diabetic kidney from biomarkers to the clinical outcomes. Thank you.
Thank you very much. I'm going to thank Professor Charles for inviting me. I wasn't so sure I liked the talk title too much. I might just comment on the fact that I've had the privilege of being president of the Obesity Society, which used to be called NASO, president of the American Heart Association, and more recently, the president of Medicine and Science at the American Diabetes Association. I can assure you that the American Society of Nephrology is never going to come my way. But anyway, so I kind of have a metaphor that I'd like to mention to you. It relates to baseball. The Japanese play a lot of baseball, so you'll like this, I hope. You're Europeans or North Africans, I'm not so sure. But the metaphor is this. It's the bottom of the ninth inning, and ultimately you're in the up at bat, and ultimately what's going on here is that you're down 10-0, but I don't have three hands. You can hear me okay, can't you? Yes, okay, I got thumbs up. So anyway, you're down a lot of runs, but in the top of the inning, the right fielder dove for a ball and ultimately sprained his wrist. So he came out of the game. The shortstop made 3 consecutive errors, and ultimately we needed a new shortstop. And you were using the 8th pitcher. Remember, you're down 10-0. And ultimately, Echo, what position can you come in here and play? So it's the idea of a utility player, but you're losing the game 10-0. And anyway, what good does it do? So you can interpret this however you want. So this talk title, understanding protective effects in diabetic kidney disease from biomarkers to clinical outcomes. I'm going to do my best with this. And Christoph, it's good to have you in the audience. I think you ought to be up here giving this talk. All right, there we go. I don't think any of these have anything to do with what I'm going to say today. So if you think they do, let me know a little bit later, would you? All right, so if we look at the history of ultimately chronic kidney disease in patients with diabetes, and in the red bar and on the left is 1990 data, and on the right is 2017 data? Anyway, ultimately, we're looking at patients with type 1 diabetes in red and type 2 diabetes in the, if you will, flesh-colored data, and people with hypertension in the blue data. And you can see, if you look over this kind of plateauing and then kind of decrease, that's an age-dependent decrease, because people probably with bad chronic kidney disease have other issues that are causing mortality. But anyway, ultimately what you're seeing is that, in fact, the prevalence is about twice as high, but the impact of diabetes, both type 2 and to a lesser extent type 1 and hypertension, is substantial on chronic kidney disease. So these data really are important in terms of the impact of diabetes on kidney disease. Now, you just heard about how diabetes relates to cardiovascular disease. We all kind of know this, and I was going to mention before she left that you may not be aware of this. Greg Schwartz, who's a cardiologist at the VA in Denver, is overseeing a study in pre-diabetes using metformin. Now, it has all the limitations of a VA study because a VA study is mostly men. I think they're going to recruit up to 15% women, but the VA is mostly men in the US. So this whole issue of metformin and cardiovascular disease may in part be answered by people who may be at increased cardiovascular disease risk. And if you think about cardiovascular disease risk in patients with prediabetes, if you're at the right end of that prediabetes spectrum from 5'7" to 6'5", your increases of cardiovascular disease are almost as high as they are when you have type 2 diabetes. So I think this is going to be an important study with metformin that maybe is going to help us know whether an indication for treatment of prediabetes may exist. But look at this vicious circle, and ultimately the back and forth between sodium retention, heart failure, diabetic kidney disease, and type 2 diabetes is something that never ceases. People with kidney disease get heart failure, they get atherosclerotic cardiovascular disease. People with ultimately diabetes get more kidney disease, et cetera. So this is a vicious cycle that continues to repeat itself pathophysiologically. So ultimately, this slide just reminds me to tell you that my colleague Mike Blaha, a preventive cardiologist at Hopkins, and I are working to try to promote a whole new medical subspecialty called cardiorenal metabolic medicine. We'd love COA to partner with us in terms of generating requests for applications. They're going to train a whole new type of fellow going forward that's going to meet the needs of patients being shuttled back and forth between nephrologists, cardiologists, and endocrinologists, and possibly even the hepatologists. We've heard a lot about non-alcoholic fatty liver disease today. So anyway, this ultimately, so when the first part of this talk relates to biomarkers. So let's look at kind of a scenario that relates to this. The clinical detection of early chronic kidney disease mainly relies on serum and urinary biomarkers, such as albuminuria, serum creatinine, and eGFR, which is an estimated assessment of renal function. I think there are multiple limitations, and they relate to the insensitivity, precision, and commonly used biomarkers like this are prone to be affected by external and internal factors, such as a high protein diet, muscle mass, daily biologic variability, including volume status. And I think that's a major reason for ultimately modifications in eGFR that are transient and can be rapidly corrected. Secondly, if we think of other ways to go about assessing biomarkers for chronic kidney disease, you can use renal ultrasound, CT or MRI, and these are used to evaluate changes in renal morphology and perfusion, but they lack clearly sensitivity in picking up people with diabetes and chronic kidney disease. And finally, ultimately, a kidney biopsy really is rarely necessary these days. We have a cardio-nephrologist here, or a nephrocardiologist, whatever we're calling Christoph. Anyway, the biopsy really reflects pathologic microstructure. And I think in general, and I'll kind of summarize this point, is used to distinguish other forms of kidney disease in a patient with diabetes that may not have diabetic nephropathy, but almost always the renal disease is due to diabetes-related changes in the glomerulus and beyond. So ultimately, if we think about screening people, these are guidelines put forth by the ADA and KDIGO. What's KDIGO? It's kidney disease, semicolon, improving global outcomes. So this is a group that's very much involved in guidelines that relate to kidney disease. And ultimately, the ADA and KDIGO group has joined together to say that who and when to screen, and in type 1, yearly starting 5 years after diagnosis, yearly starting at diagnosis in type 2, and how to screen, spot urine for albumin-creatinine ratios, and estimation of eGFR, and what to do if you have a positive result, evaluate possible temporary or spurious causes, consider a cystatin C, and I'll come back to that in a moment, and creatinine to more precisely estimate GFR, and only persistent abnormalities define chronic kidney disease. A one-time sample may not, because of all the issues that are confounding an interpretation of a single diagnostic entity. And then ultimately, what defines kidney disease? And I think, somebody mentioned the term microalbuminuria. I think that's being dismissed now, is it not? Urine creatinine, albumin creatinine ratios above 30 is just proteinuria. We're not calling this microalbuminuria anymore. I mean, 30 and 300 are etched in our brains, but that terminology is being changed. Persistent eGFR under 60 mils per minute, an age-related issue that needs to be taken into consideration, and also other evidence of kidney damage, which may require a more detailed workup. All right, so Christoph talked extensively about albuminuria. I'm not going to spend a lot of time here, but I took several slides out that related to this because he covered it so well. Ultimately, albuminuria now defined at this level of 30 milligrams per gram, ultimately, and followed forward as the early detectable modification in people with diabetes and chronic kidney disease. And ultimately, moving forward, we move into progressive levels of albuminuria, and ultimately, along the path of that, estimates of eGFR or other measurements of renal function should be modified. So if we think about this, and I think this is kind of an interesting problem that I was seeing clinically before I stepped back from seeing patients, was ultimately patients with diabetes who had no proteinuria, but had decreases in eGFR. So this now represents about 20% of patients with type 2 diabetes, and more commonly even in type 1 diabetes. So what's this all about? Well, here's the workup of these patients that have diabetes and they have no proteinuria. So how do we go about evaluating these? So this is called normoalbuminuric diabetes with renal insufficiency. These data are at Nanjing, China. And ultimately, it relates to the presence or absence of other complications that relate to microangiopathy, including proliferative diabetic retinopathy. And both of these patients have low urinary albumins. So here, if the eGFR is less than 60, ultimately you make the diagnosis of normal albuminic diabetes with renal insufficiency. And if they don't meet this level of EGR, you just routinely check these people going forward. So this slide's only being shown to bring to your attention the fact that not everybody with diabetic kidney disease has proteinuria. And it may be up to 20% of patients with diabetes and kidney insufficiency. Now, this slide looks at a classic paper by Mussup et al., published in Kidney International now 20 years ago. And this was kind of one of the early observations that cystatin C may be a better estimate of diabetic kidney disease and diabetic nephropathy than serum creatinine or calculated EGFRs. So here we're looking at the relationship between cystatin C and evidence of renal function using chromium-51 EDTA clearance, which is a measure of kidney function that's more specific. Ultimately, this correlation looks a lot better than this. Nothing perfect here, but cystatin C is more expensive and it doesn't need to be routinely done, but sometimes it can be a tiebreaker, ultimately in terms of whether an EGFR modification may be due to other factors. So here are the issues that relate to non-GFR determinants that affect EGFR. So we know a number of things. I modified this graph to include volume status because ultimately modifications of EGFR that relate to volume alterations are very, very common clinically. But ultimately, here are the things that affect the creatinine level, and we've covered this to some extent in terms of muscle mass, age, sex, ethnicity. And here are the things based on epidemiological observations that have not been adequately considered as confounding variables in terms of cystatin C. So ultimately, we have some limitations for both measurements, but in general, cystatin C has been felt to better represent renal function than ultimately EGFRs that are calculated. But I think right now, they're more expensive and require a little bit more consideration before they're drawn. All right, now let's look at a couple of other biomarkers that I'm not going to show any data on, but I'm just listing these as potential things to look at going forward in terms of how we assess diabetic kidney disease. Here's a deviation and validation of a machine learning risk score using a biomarker patient data to predict progression of diabetic kidney disease. So this is a machine-driven, AI-based approach. And this, for some reason, got left behind. Okay, so this was work out of the Mount Sinai Icahn Medical School in New York that ultimately developed a method that I'm going to show you in more detail in terms of assessing multiple risk factors for chronic kidney disease that have resulted in an outcome that I think I found quite interesting, and I think you might too. So this is called the Kidney Intel X risk calculation for diabetic kidney disease. And what we have here are a series of variables, including both TNF-alpha receptors, kidney injury molecule 1 or KIM1, ratios. I don't like ratios, I'm sure you don't either, but anyway, ratios are part of this. EGFR as usually calculated, UACR, hemoglobin A1C, systolic blood pressure, liver function test, specifically the AST, platelets, and serum calcium. Now this looks like a grocery store shopping experience, but ultimately the model is based on these components. And here you see the relative contribution based on low contribution to high of these various components of this model using the Shapley additive explanation plot. Now over here are people with no progression of kidney disease whose scores are down here in blue. And if you get increasingly to the right where there's progression of kidney disease, now this is orange or yellow, whatever. But what this is indicating is that these scores can be estimated, and how do they perform against the usual methods? Well, I'm going to turn to the Canvas study, which was just covered. This is a study with canagliflozin, which is a cardiovascular disease outcome study. And here's the patient population. I won't go through this in detail. Age 64, 32% women, mostly white, CVD history in 62%, history of heart failure in 16%, et cetera. And here's their levels of eGFR. 9.8% were between 30 and 45, 33% 45 to 60, 41% 60 to 90, and a few patients above 90. And here's their urinary albumin shown here. So I just wanted to give you the baseline characteristics of this canvas assessment of renal function. So let's look at the overall data. Here's the breakdown for canagliflozin and placebo. So here are people that are considered to be at low risk, intermediate risk, and high risk based on the kidney Intel X profile in terms of estimating risk. And here's the KDIGO representation of moderate risk, high risk, and very high. So if we compare low to moderate or intermediate to high, or however you want to do this, and you can really decide how you want to do this, these risk ratios for progression of outcome, and here's the composite outcome, an eGFR decline of greater than 5 mils per minute per year. That's a pretty rapid decrease. And that was using the 6-week eGFR as the baseline. Greater than 40% sustained decline in eGFR or ultimate dialysis or transplantation. So that's a reasonably good outcome. But here we're seeing the kidney Intel X outperforming in terms of predicting, and that's true of the canagliflozin group and in the placebo group. So if we look at this in a plotted form, here's looking at patients at low risk versus the high risk, and these are the relative abilities of the kidney Intel X versus KDIGO in terms of prophylactically indicating who's at greatest risk. And I think this needs to be ultimately looked at in additional trials going forward, so we have a little bit better explanation about how this can be validated by other trials. And here we're looking at people who are determined to be at high risk, baseline, lower risk, and et cetera, and their outcomes going forward over the tertiles of examination in terms of the percentage of patients with the primary endpoint as previously described. So I find this kind of novel and maybe a biomarker that's going to be ultimately more capable of being applied in the clinic more effectively than currently what we know. Then there's periostin. What's periostin? Periostin is a gene product that ultimately is involved in organogenesis. But interesting, particularly for kidney disease, is you particularly get more inflammation and more fibrosis. This can be really a very important biomarker of progression of kidney disease. Not so much the early onset of kidney disease, but we need to keep an eye on this. And I would presume if the liver is failing too, that this may not be so specific to the kidney, because this is a protein that's expressed only during organogenesis, when we're all in utero, and also maybe early in life, but then gets shut down after that unless there's ultimately changes that relate to inflammation and fibrosis. And Peter, I don't know about atherosclerosis, whether this has been carefully examined in that space. And finally, the effectiveness of functional magnetic resonance imaging for early identification of chronic kidney disease. This is a systematic review of not much literature, and I'm just putting that up there in terms of using fMRI as another tool to look at early kidney disease related to diabetes. All right, and the final thing I'll mention here in terms of new biomarkers that might be potentially of interest, and this is the epigenome. And ultimately, this analysis looked at a series of genes, looking at hundreds of thousands of sequences. And I found particularly interesting, here are 6 of the 32 genes they thought were relevant in terms of the power that related to their identification. This relates to methylation. So methylation of all of these genes either positively or negatively related to, and by the way, these measurements were made in peripheral circulating blood and the glomerulus in patients with diabetic kidney disease. I found particularly interesting this REV1, because REV1-like proteins act as a scaffold that recruit DNA polymerases involved in translesional synthesis of damaged DNA. So if this methylation is reduced, that means ultimately this gene is more readily expressed. And this may be another way to go about identifying patients with chronic kidney disease. All right, so I don't think Christoph likes these heat plots, but nevertheless, the ADA and KDIGO are going to put this plot up that relates to degrees of chronic kidney disease is related to eGFR calculations, and this relates to the amount of albuminuria. So this gives you a plot in terms of how to assess patients going forward who in fact are diagnosed with having chronic chronic kidney disease. So in closing then, the second part of this talk was new developments for drugs to modify the progression of chronic kidney disease. You've heard about SGLT2 inhibitors. We'll look at those briefly. You heard from Christoph about finerenone. I'll cover that briefly. And also the GLP-1 receptor agonist. So let's begin with work of Kathy Tuttle in Seattle, who in fact identified the fact that the proximal absorption of glucose in the proximal tubule is really a higher TM for glucose. So what's a TM? It's the level of glucose where glucose reabsorption, in fact, reaches a threshold and glucose is lost in the urine. So for patients with diabetes, it's about 12 millimolar, or about 220 milligrams per deciliter. For patients with diabetes, most of you, it's 180 or about 10 millimolar. So the threshold for urinary glucose loss is higher, and that's because the SGLT2 transport protein in the proximal tubule is increasingly prevalent and active in patients with diabetes. And there's other changes in the glomerulus related to diabetes. But here, in the open circles, as shown down here, that's where the SGLT1 receptors are in the kidney. They're probably in the proximal, descending loop of Henle. So ultimately, the SGLT1 impact by the inhibitor sotagliflozin probably has some role to play in diabetes management. But SGLT1 is also expressed in the gut and can affect glucose absorption. And I think the important thing to know about that is one of the adverse effects of the SGLT1 and 2 inhibitors is diarrhea. And that can be fairly limiting because if you're malabsorbing glucose, what happens? Well, the bacteria in the gut have something to say about that. Now, if you look at the metabolic effects of SGLT2 inhibitors, they're multifactorial, including reducing glycemia, weight loss, blood pressure. By the way, the amount of weight loss with SGLT2s is not very much. So the independent effect of that on the kidney could be questioned. Lowering blood pressure by reducing sympathetic tone, a modest effect of SGLT2s. And reducing hyperglycemia, actually the A1C improvement in patients living with diabetes treated with this class of drugs is not all that impressive either. But we know there are other mechanisms that have been described, and there are kidney benefits and heart benefits, which you just heard about. So let's look at that data kind of in a summarial form. So this is the effect of SGLT2 inhibition on chronic kidney disease in patients with diabetes, and here's the bottom line. It's about a 30% reduction in the progression of kidney disease. And that, down here, by the way, is that same data plotted for people without diabetic kidney disease. And here are a number of trials now that are increasing in number that show a similar benefit, and EPIKidney was the recent of such trials. Now, finerenone is a non-steroidal mineralocorticoid receptor. That sounds like almost an oxymoron, but in fact, that's how the drug works. It's not like spironolactone or pleuronone. In fact, it is a non-steroidal mineralocorticoid receptor antagonist. And ultimately, the data for kidney disease here is based on this trial called Figaro and Fidelity, 2 trials that have been combined now to look at the outcomes of using finerenone. Inclusion criteria, serum K less than 4.8. This class of drugs also causes hyperkalemia. So that's something you need to watch. A little bit less than spironolactone, but you need to watch that. Patients either had an UACR of greater than 30 to 300 and an EGFR of above 25 up to 90, or they had an albumin excretion rate of 300 milligrams per gram of creatinine, up to a maximum of 5 grams. These are nephrotic syndrome patients, and an EGFR above 25. And the primary outcome is cardiovascular disease composite outcome, CVD death, MI, stroke, or hospitalization for heart failure. And of course, we're interested here in the kidney outcome, which is a EGFR decline or renal death, a composite outcome, or a change in UACR. So here are the data for finerenone. Christoph, I think, showed these same data yesterday, I guess it was now. So ultimately, the data on the left look comparing placebo with finerenone in terms of the least squares mean ratio to baseline. These are months since randomization, so that shows the benefit. And on the right, ultimately showing also a benefit in terms of months after randomization of the impact of the various outcomes. So finerenone works and modifies the natural history of kidney disease by modifying ultimately the benefit in terms of the protein loss that occurred in these particular patients. Now, turning and closing to the glucagon-1 receptor agonist, here the data are pooled from 2 trials. This is liraglutide used in this LEADER trial, and also semaglutide used in the SUSTAIN-6 trial. And what we're looking at here is the decline in proteinuria here in the various trials. Actually, we're looking at here in the blue is the semaglutide data, and in lighter blue, the liraglutide data. And in both of these settings, ultimately, the GLP-1 receptor agonist modified the natural history of once-weekly semaglutide or once-weekly liraglutide on the natural history of kidney disease in these 2 GLP-1 receptor agonist trials. And here's the trial separated, the pooled data, SUSTAIN-6, which, by the way, was more weight loss, and that's the trial that was associated with less stroke too. And here's, in fact, the LEADER trial with less of an impact, but also together these trials look to show a benefit. And I'll mention in closing that the FLOW trial is being ongoing right now. This is comparing a moderately high dose of semaglutide at 1 milligram in over 3,000 patients with type 2 diabetes versus placebo. And there are the trial objectives shown to the right. Now, just to summarize, showing Ian DeBoer's publication about the 88 kidney disease improving global outcomes approach. Lifestyle I didn't even cover today because I think we all kind of accept that. We try hard, but it's not successful. First line therapy in terms of diabetes management that also relates to kidney disease. Metformin needs to be restricted in patients with EGFRs under 30, not restricted anymore in people with myocardial disease or heart failure, at least up to an EGFR of 20. SGLT2s are probably the drug of choice here rather than the GLP-1 receptor agonists. And then ultimately downstream, the additional of additive therapy. I should mention that finerenone is not cheap. So that's an expensive prescription to write, but you may be capable of getting it with coupons and things like that. So I'm going to stop there with this scenario published in Kidney International fairly recently. So sorry for all the trouble with this. Thank you for your attention.